So I'd like to introduce our judge for today. We have Angela Cottrell, head of Peninsula Foundation School, Royal Devon and Exeter Hospital.
Hello, welcome everybody. This is poster group P. I think we've got 11 posters that are presented today. And after the first 5, we will have a 10-minute break, followed by the remaining poster presentations. Each poster presenter has 2 minutes and 30 seconds to present their slides, and then I will ask for questions for up to 3 minutes. And please, we would like you to keep your presentations to the allotted time. All the poster presenters are expected to attend the whole session. You will have all received the order in which the posters will be presented, as shown on the PowerPoint currently on the screen in front of you. The winner of this group and the runner-up will be announced this afternoon during the session on the main stage at 5 o'clock. And before we start, just like to say thank you for all your hard work and your fantastic effort into the work that you've done.
Thank you, Angela. So just to clarify, I'm managing the slides. So please say next slide is necessary to move from your first to second slide. And as the judge explained, you're expected to complete your presentation within the allotted time, and I'll call time at 2 minutes and 30 seconds. I'll then invite the judge back after for up to 3 minutes and give a verbal 30-second warning and set time at the end of those 3 minutes. There'll be a short pause whilst the presenter who has finished mutes their mic and the next presenter unmutes themselves. Now, please can everyone apart from the judge and the presenters of the first poster have their audio muted. If we're ready to begin, first up we have Dr. Jordan Isine presenting on raising awareness and improving compliance, a 2-cycle audit of VTE prophylaxis in surgical patients. Please start when you're ready. Thank you.
Hey, hello everyone. So like that title said, I'm Jordan and I'm one of the doctors, F1 doctors from Devon, and this project is about raising awareness and compliance of VT prophylaxis in surgical patients, and this work stems from a very practical issue, which is about new junior doctors missing key steps in a VT risk assessment, and it was all about doctors who just started working, so it was their first job, and that first job happened to be surgery in a new trust and often with its own policies. So this audit really came about because of concerns raised by the nursing staff on the ward and also by consultants on ward rounds about notable incomplete VT documentation. And you can see that in the bottom left of the slide. So the way this project worked was that we focused on one surgical ward and we reviewed compliance with the trust's VT risk assessment, and looked at the different specifics that that pro forma has. And the main things we wanted to understand from that first audit cycle were junior doctors aware of this problem? Did they realise that a formal signature wasn't sufficient alone? And did they understand the importance of assessing and prescribing for non-pharmacological measurements like TED stockings? So this project worked by developing a series of low-cost and educationally targeted posters addressing these gaps, and you can see that on the right-hand side as an example. They were displayed across the ward that we focused on, which was a mixed surgical ward, and they were also put up in the doctor's office. The posters included things like a completed pro forma, the rationale behind full documentation, and the financial and patient safety consequences of incomplete assessments. The posters also highlighted which aspects of the pro forma were completed well or poorly, and also gave some important information on adjusting for patients' weight and renal function. We knew posters alone might not have been enough, so we ensured they were well received by getting feedback from the consultants and ward managers before we implemented them on the ward. And we also gained further insight into the problem through a survey, which we'll see on the next slide. And that survey was from junior doctors working amongst the 3 surgical firms on that ward, which happened to be upper GI, colorectal, and urology. So if we move on to the next slide, which is about the outcomes. So after that audit, the question was, what changed exactly? Now, before the intervention, most junior doctors were aware that an assessment was needed and that pharmacological doses should be adjusted for weight and renal-based patients. However, many were unaware of the need to redocument the re-audit process within about 24 hours or so, and also they were unaware that they had to prescribe or not prescribe non-drug prophylaxis, such as TED stockings. This is quite an important aspect for surgical patients due to how operations and procedures can change the patient's clinical picture. Um, Often this is better in cases, but unfortunately there are times where patients deteriorate post-surgery or procedure. So it was something that had to be considered quite heavily.
I'm so
Uh,
sorry, that's time.
okay, thank you.
Brilliant, thank you. Thank you, Jordan. What made you choose posters rather than any other sort of intervention?
I think the main reason for that was seeing previous projects that had been done in the trust were mainly started with a poster. And I wasn't sure how far this project was going to go, so I thought it was quite a simple, targeted way to look at what, just making doctors aware of what we weren't doing or were doing well, and how that could perhaps be improved.
And do you think it was an effective intervention? Is there anything else that you've considered when you've reaudited it?
The thing that was most effective was about the actual overall pro forma being completed. That was something that was particularly missing. We didn't find much of a change in prescriptions, but just actually having people think about why they're assessing or what's led to the assessment being made was a positive outcome. And kind of going forward, I want to implement this across more wards and not just surgery, but also medicine.
And what about places that don't have space for posters? Have you got any other interventions that you could use?
So hopefully, again, it's not going to be for this year, but when we have an electronic system make its way down to Torbay, I think that would be a very good place to start putting in prompts into the software. I know that's often a common intervention that's used, and it seems to be quite successful. So it'd be good to see if that does work down here.
Brilliant. Okay. Thank you very much, Jordan. Thank you.
Okay, thank you.
Thank you very much. We'll move on to the next presenter. Next, we have Saeed Mohammed presenting on documentation of penicillin allergy.
Hi, hello there. My name is Mohammed. I am currently as a joke working in acute medical unit. Title, penicillin allergy documentation. And the reason why we selected this audit was because 90% of those patients who are labeled to have penicillin allergy, 90% of them have no true allergy. And that's why we feel we have to do something about it. And which, as we know, penicillin and beta-lactam drug as general, including penicillin, are one of the most important medication to treat bacterial infection. So we did 2 BDS cycle in geriatric department to check how well penicillin is documented compared to NICE guidelines. After doing the fastest the data collection, which I will show in the next slide, we did these interventions, including sending emails to doctors to remind them penicillin allergy documentation, and also we did some presentations in antimicrobial stewardship group meetings. Then we did our second cycle, and we collected data again, which I will show in the second slide as well. And then we did the further steps, including displaying posters, departmental presentations, and also penicillin documentation was added in the induction handbook. And we started delabeling some patients that are not really allergic. For example, sometimes some patients are they are labeled as allergic, having just a side effect like diarrhea and vomiting. And also we send again reminder emails to doctors and pharmacists. Second slide, please. Yeah, as you can see in the diagram on the left, that was the fastest cycle before intervention. And as you can see, a type of the reaction, unknown reaction has dropped from 61 to 52. And also severity, which was not completely at the beginning, not recorded in 100% to now, has improved 10%. And the source of the reaction has improved 5%. The most important element was that doctors and pharmacists are very familiar now the correct documentation of penicillin allergy. Of course, we face some challenges, which include because we did our audit in geriatric department, and it was quite sometimes difficult to take correct history because patients are often confused, and because of having background of dementia. And also we face some challenges with compared because of the doctors' rotations that need constant updating. And the last also, correct the labeling, of course, needs a greater technique and accuracies. And of course, we can delabel those patients who are not correctly labeled as allergy, but for those truly who have allergy, it needs like testing, and that would need really some challenge as well. One very important to be noted is that 80% of those patients who are initially allergic, they lose their allergy after 10 years.
I'm so sorry, that's time.
Thank you.
Thank you.
Brilliant. Thank you very much, Dr. Mohammed. So with the next part of your cycle, what do you think you're going to do to further improve things?
And I think we would have done I would say would do in a like acute units, or maybe in ED where the turnover is faster. And also we probably involve in GBs as well, sending emails to just try to delabel where the patients are in the community.
And so the whole point of this is to make sure that people are on the right antibiotics. Did you find that this has an impact on antibiotic prescribing?
Yes, as you know, all doctors will really relate this. When you see patients who are allergic to penicillin, then you will be very anxious of what I'm going to do next, to look options. And as I said, 90% of those patients are not truly allergic. So removing that would be very incredible, and will be good for patient safety.
Brilliant. Thank you very much.
Thank you.
Thank you. Next, we have Ms. Mehek Malhotra presenting on assessing the quality of orthopedic weekend handover against the RCS guidelines safe handover. Please start. Thank you.
Hello, my name is Mehek and I'm working as a CT2 in trauma and orthopedics. My audit is about analyzing how our practice in a DGH in trauma and orthopedics compares to the Royal College of Surgeons safe handover guidelines. So as a background, the Royal College of Surgeons produced some guidelines in 2007 on safe handover practice, in which a minimum data set was recommended for inclusion when handing over patients to incoming surgical teams. We realized that the weekend team often doesn't have much familiarity with the patients. So we decided to audit all the weekend handovers from the electronic handover system over 4 weekends in the month of 2023, and we analyzed the handover against the RCS guidelines. We found out that there were multiple deficiencies in handover, so we implemented multiple interventions. The first and most important intervention was a teaching session that we held as part of the induction for all the resident doctors on safe handover. We also disseminated information via some emails, and we made posters in which we included the checklist for the things that need to be included at handover, and we displayed them all in the doctor's office and also in the wards. In addition, we created an online template of a dummy patient in which we included all the points that needed to be included, and we encouraged the resident doctors to use that online template whenever they are preparing the handover for the weekend team. We gave these interventions a 23-week period, and then after that we did a post-intervention audit which was conducted over 4 weekends. So the first cycle included 45 patients and the second cycle included 54 patients, so the number of patients was quite comparable. Can we have the next slide, please? So after the re-audit, we realized that the documentation had improved significantly, specifically the documentation of date of admission, which improved from 60% to 84.6%. The documentation of results of significant or pending investigations also improved from 44% in the first cycle to 61.5% in the second cycle. The management plan was included in 82.7% of the patients in the second cycle compared to 71% in the first. The compliance to the other parameters was either the same or it decreased slightly. For example, the percentage of handovers which included resuscitation plans decreased from 84 to 76%. Same with the frequency of review, which also slightly decreased. From this audit, we learned that. Thank you.
Thank you very much. So what was it that triggered this audit? So I understand the Royal College of Surgeons guidance, but was there a specific safety event or something that caused you to look at this?
There wasn't one specific event, but in our DGH, I often used to work on the weekends. And after not knowing the patients the whole week, I was suddenly in the ward on the weekends, and there were 50 something patients to see between two of the resident doctors. And sometimes the nurses would call us to review a patient, and we had no idea about the patient. So we had to look at the electronic handover for them. And sometimes some key information was missing from those handovers. So we had to spend a lot of time going through the patient's notes. And that was that made us very inefficient. So we thought that if the electronic handover contains the salient points, then it would improve the efficiency of the weekend team.
And did you specifically look at that? Did you look at the sort of satisfaction of the team before and after?
Yes, so I conducted a very informal survey of the resident doctors before we implemented the changes, and there were quite a few things that we picked up. The main thing was that the resident doctors were not aware of the guidelines, and they didn't know which information was important, and sometimes they would include information which was not that important. So having that template gave them the means to filter out the more important information. So they were overall more satisfied after we introduced these guidelines.
Okay, thank you very much.
Thank you.
Thank you.
Thank you.
Next, can we have Ira Ahmed presenting on the use of patient information leaflets to discharge patients following laparoscopic or open appendectomies? Please, can you start when you're ready? Thank you.
Of course. Good afternoon, everyone. My name is Ira. I'm one of the F2s working at Blackpool Hospital, and I'm honoured to present to you our patient safety audit regarding the pre-existing patient information leaflet that we had in the general surgery department to help support the discharging information that we were providing to our patients on discharge. So essentially, a bit of a background on our audit. So as you're probably already aware, patient information leaflets are an essential part of surgical aftercare, and they're strongly endorsed by big national bodies such as GMC and Royal College of Surgeons, because they help to improve patient understanding and help to also reinforce post-operative instructions for patients as well. So our methodology was a retrospective audit. We looked at data of about 3 months, and then we called up patients utilising our own standardised questionnaire that you can see on the screen, just to make sure that we were picking the key domains that was required when we were discharging patients safely. And then we would phone patients up, and then we would gather their sort of descriptive data and then use that as part of our results. And what we found is, after cycle 1, we found that most of the post-op advice that we were providing was satisfactory. However, there were some key things that we wanted to highlight. So actually, less than half of our cohort was actually receiving this leaflet, so it's not very many. Actually, 21% of patients found that the wound care advice that we provided wasn't adequate enough for them, and almost a quarter of patients didn't receive safety netting of red flags and when to represent. So obviously this sort of highlighted a massive patient safety issue, could compromise patient safety out of hours, and something that really needed to be addressed. So what we did was we went away and we updated this leaflet that was about 20 years old, so as you can see on the screen, and we formatted it in a way that was a lot more clearer and concise for patients to be able to read and take home with them. Next slide, please. And then we completed a recycle after about a month, and we found that our results showed that much more patients were satisfied with the discharging information now that was provided, especially in terms of pain relief and safety netting of red flags. So that was a real nice positive to see. More patients were receiving the leaflet overall, and we actually categorized how we looked at the data in 2 different ways. So we looked at if the patients definitely did receive the leaflet and if they didn't receive the leaflet. And as you can see from the 2 graphs, those who did receive the leaflet, there was much more satisfaction in those patients compared to patients who didn't receive the leaflet at all. They were unsatisfied. So this concludes to us that actually providing a patient information leaflet can significantly improve post-operative advice outcomes for these patients, and actually it's an effective method of ensuring patient safety, and it enhances patients' recall and understanding of the procedure that they've had. Some limitations that I'd just like to make you aware of about our audit. Our cycle 2 cohort was a lot smaller than cycle 1, so that could impair the validity of our results, so something to take forward for our next cycle. And there was still not enough patients receiving the leaflets as we would have liked. So again, something that we would have liked to pick up on the next cycle. Thank you.
Thank you very much. Excellent work. One thing that I've written when I looked at the poster before, my question was, the wound care advice was less satisfactory after the intervention. Is that right?
Yeah, exactly.
Why do you think that?
So we felt that, and the reason why we think that is because our cohort also was half the size as cycle 1. But there are also other factors that, because obviously it's very subjective from what the patients are telling us and how they feel. If there are patients who've had a procedure and now they've gone home and they've developed some sort of post-op wound infection, they automatically will probably not be happy with the advice that they were given. And we found that a lot more patients were returning back. Because maybe our leaflet was actually making a positive change, and they were becoming more aware of post-op wound infections, but also the fact that they had developed these infections, perhaps they were confused as to what we were actually asking of them. Maybe they were not happy with the care rather than it actually being the instructions that we provided on discharge. So I think when we go into our next cycle, there was also what I noticed in interview bias. So obviously it's just us as junior doctors calling up these patients. Maybe it's the way that we're wording the questions. It differs between each of us interviewers. So maybe we just need to have a bit of an informal chat about how we should be asking these questions to patients. It should be more open questioned rather than closed questioned. So I think these are the factors that probably could have caused that, to be honest with you.
And how do you think you can increase your leaflet distribution?
So the way we increased it after our intervention was we just emailed the wider MDT staff. So I think next time we'll be holding like a presentation in the next clinical club meeting, so that all of the staff there are present, so we can make a much bigger impact, and also be presenting these findings so that they can see that the leaflet does actually help. We just need to be getting it out more often. And it's not always the doctors that will be giving the leaflets, because surgical ward rounds happen very quick. So it relies on nursing staff, it relies on physios. So we definitely need the wider MDT to get on board with it.
Yeah. Okay, thank you very much.
Thank you.
Thank you very much. Next up, we have Dr. Imal Hafiz and Dr. Ong Tien presenting on improvement of the early diagnosis and management of CAP by auditing against CAP bundle by BTS. Please start when you're ready. Thank you.
Everyone. On behalf of our team, Imad and me will be presenting on our QRP project, which focuses on improving the early diagnosis and management of community-acquired pneumonia. Community-acquired pneumonia is a common winter presentation in the ED and is associated with high mortality if not treated promptly. To assess the quality and timeliness of the community-acquired pneumonia care bundle being delivered in a hospital, a retrospective audit was conducted on adult patients admitted between June to October 2024 with a primary diagnosis of community-acquired pneumonia. Pediatric cases were excluded. We then compared their care against 4 key components of the British Thoracic Society Community-Acquired Pneumonia Care Bundle, which is firstly, chest x-ray should be performed within 4 hours of admission. Second, oxygen should be prescribed within the first hour if required. Third, CURB 65 scores should be calculated for patients with radiologically confirmed community-acquired pneumonia. And finally, appropriate antibiotics should be administered within the first 4 hours of presentation. These findings were then analyzed and presented locally to inform targeted improvement strategies. Next slide, please, and over to you, Dr. Imad.
Yep. So basically, after collecting the data, we found out that overall we've stuck quite well to the bundle, but the primary cause of concern was that about more than 75% of patients didn't receive the oxygen requirement set out by the BTS, which is within 1 hour. I mean, it's varied, the timing interval, the time after presentation, the oxygen prescription were varied, but it was quite significant. And so as a result of that, we as a collective team had gotten together and discussed what interventions we can do to ensure that we can address this issue at its core. And I think the first one was we placed posters around high patient turnover departments like the acute medical unit and the A&E, so as to remind staff as to the guidelines that are in place and how we what we are expected to do in order to ensure and optimize patient safety and care. And also in collaboration with the IT team at our hospital, we're in the process of integrating a notification system which presents real-time alerts on our EPR whenever a patient has been inputted as having a diagnosis of a CAP. And I think what we've learned overall during the course of all of this is that, doing systematic audits, we can understand where our pitfalls are in patient care and safety, and also just embedding prompts, into various easily accessible resources to ensure guideline adherence. So that wraps up our presentation, and we're open to any questions, please.
So can I confirm, you did the intervention, did you re-audit?
So to maintain the factors, to keep it the same, because we audited this within the winter months when the peak incidence of CAPs are at their highest. Not within the winter months, but between June to October. And so we are going to re-audit this information, the same set, amongst adult patients in that time frame, collect that data and see whether our interventions have been successful. I think from an informal perspective, we've noticed that there have been slight improvements. Staff, from word of mouth, from informal emails and things like that, we found that there has been an increased adherence to these guidelines. But again, obviously, we are waiting on the second cycle just to make sure that we get formal data to present. And
I suppose with the delays in, for example, prescribing oxygen, is there any chance that if you're just looking at a time for a prescription, that the oxygen could have been on for a while before prescriptions? Or
so we went through the data on that front as well, and I think we obviously went through patient documentation. We went through so we use an electronic prescribing system, so seeing that as well. So we've filtered out the situations where oxygen has been on for a while, because obviously nursing documentation says patient is on oxygen, and we compare that with our prescribing records. and we determine, okay, no, look, this is just an error in the sense of actually just not being, prescribed on paper or on like a record basis, rather than like an actual cause of patient concern.
Okay, brilliant. Thank you very much. Thank you.
Thank you.
Thank you. We're now moving on to our final presentation for this session, for this section. We have Pavan Basra presenting on a quality improvement project on prostate-specific antigen testing awareness in patients with an increased risk of prostate cancer. Please start when you're ready. Thank you.
Hi, I'm Pavan. I'm one of the F2s. I did this project in my GP placement, and sort of the background behind it is that 25% of Black men will be diagnosed with prostate cancer in their lifetime, and prostate cancer still remains the second highest cancer mortality in the UK. Currently, there isn't a screening program for prostate cancer, but trends in PSA are still used by urology and oncologists throughout patients' treatments. According to NICE guidelines, it should be offered to at-risk patients, so patients who are of Black ethnicity, male, and between 45 to 70 years of age, if it's requested. But sort of the levels of awareness of this, whether patients know that they can ask to be tested, is not known. So we set the task of, in a 2-month period, ensuring that 100% of the at-risk patients were contacted about PSA testing, and 75% would either then have a PSA recorded or have formally declined having the testing after discussing the risks and benefits of PSA testing. The group of patients was identified from our GP database, and we completed 2 cycles in which we called and texted patients, sent them information leaflets, booked them in with phlebotomists, and they were then followed up by GPs if necessary, and referred on the 2-week wait pathway as per the 2-week wait guidelines. Next slide, please. So what we found at baseline was 22% of patients had a PSA recorded. The population group was around about 116 patients. After 2 cycles, this was increased to 68%, which includes patients who declined testing. What we learnt was actually patients having a baseline PSA is very useful, because for any patients that return in the future, we have a marker of where their levels were prior to any illness. We need to improve education and pathways for patients. They're an at-risk group. They don't know that they are entitled to ask for testing. They also don't know the risks and benefits of PSA testing. So it's really important that there's better education for them, and also increasing awareness amongst healthcare professionals, making sure that we can offer it to patients who are requesting it, and ensuring that they understand the benefits of the testing. Reflecting on how the process went, just making sure that I involved everyone quite early on, making sure the phlebotomists were aware that we're increasing the number of patients coming in for testing, and making sure that the correct tests were being taken at the time. Yeah, thank you.
Thank you very much. So you mentioned in the presentation that 1 in 4 of these men will have prostate cancer.
Yeah.
And what do you think about your screening results?
Our screening results were quite positive, actually. We didn't have anyone identified as having prostate cancer. There was 4 abnormal test results, and they then went on to see urologists, and they all had an MRI scan, which is now really useful and sensitive for prostate cancer. So that was quite beneficial. Obviously, there's still a proportion of patients that were not, that didn't respond to our being contacted. So yeah, it's difficult to sort of make a full comment.
But what do you think about PSA being a screening tool for prostate cancer? So you screened a high risk population with a high uptake, and you've not identified any prostate cancer. Do you think your PSA should be what you use to screen?
No, I don't think PSA should be used what should be used for screening. We know that there are patients who will have a normal PSA and still have prostate cancer. But I think the fact that it's just useful as in primary care to have a baseline PSA result that we're comparing a change to. So I think a change would be more concerning if patients came in with new symptoms and their PSA is more elevated from their baseline. I think that would be really beneficial for us. And also when we're referring to urologists and oncologists, they still use PSA to track progress in response to cancer treatment. So whilst it's not suitable for screening, it's still the mainstay of how we monitor treatment and how we refer to our other colleagues.
So you've not identified any prostate cancer in a high risk population, but they're still high risk. So how in primary care, how are you following these people up? Because you can't reassure them that they don't have prostate cancer.
Yeah, so I think ensuring that patient, when we contacted the patients, we made sure that they were aware to get back in contact with us if they were having any urinary symptoms, any of the red flag symptoms that are listed. So I think generally it was a good way to educate patients about it as well, just from that perspective. And then at my GP practice, they were saying within the PCN, they're looking to start inviting patients in to have PSA testing annually. So that would be a program that they're thinking about starting up again. They used to do men's wellness checks, but I think they lost the funding for that. So that's something that might be coming back in, inviting patients, high-risk patients back in again.
Yeah, because in a way you don't want to falsely reassure all these men. And you really have to follow them up, don't you? By definition. Okay, thank you very much.
Thank you. Thanks.
First up, we have Dr. Rebecca Jenkins and Dr. Mark Jenkins presenting on the impact of artificial intelligence software to help detect skeletal fractures on emergency department x-rays. Please start when you're ready. Thank you.
Hi, so we're Rebecca and Mark, and this is our project looking at the impact of artificial intelligence software in helping detect skeletal fractures on emergency department x-rays. So BoneView is a NICE approved clinical AI application which can detect fractures, dislocations and effusions on skeletal x-rays. Relevant literature reports the missed fracture rate on skeletal x-rays to be between 3 and 10%, and our study aimed to assess the impact using AI software on detecting bony injuries within busy emergency departments. So as part of the Northern Ireland pilot study, BoneView was implemented within the Northern Trust, which comprises of 2 busy emergency departments and 1 minor injuries unit. The process comprised of 3 phases. So phase 1, which was BoneView and pre-BoneView go live, which involved the review of 1,000 consecutive musculoskeletal images, and data was collected with regards to the radiology report and the ED clinical evaluation. These were subsequently compared against an expert radiology opinion, which acted as our ground truth. So phase 2, these images were then moved into a test AI arena, and BoneView was applied to this baseline data and the performance was calculated. This was done to ensure that the results did not worsen, which it did. And in phase 3, in BoneView Go Live, AI was implemented within the Northern Trust. A further 1,000 consecutive musculoskeletal imaging episodes were captured and the following information collected. So the radiology report, ED clinical evaluation and the AI results. Next slide, please. Sorry, Nick. Thank you. So sensitivity, specificity, accuracy, and area under the curve of each reporting entity were calculated and compared against results using AI. Sensitivity for the ED interpretation increased by 14.5% with the application of BoneView, whilst the sensitivity of radiology report increased by 5.3%. The ED missed fracture rate decreased from 6.7 to 1.18%, which was statistically significant. The ED clinical evaluation with bone view assistance was comparable with the radiology report, and ultimately the use of AI improved sensitivity for ED clinicians and radiology reporting staff, leading to a reduction in missed fractures and thus improving patient safety. This pilot has resulted in a rollout of AI in all emergency departments within Northern Ireland. Thank you.
Thank you very much. So this is the standard of care now, is it?
So this is a pilot study, which is the first study done within Northern Ireland. So the next step now is that it's going to be rolled out into sort of all emergency departments within Northern Ireland, and then re-audited again to then, I guess, ensure that it is having the intended impact.
And so is the plan to remove radiology reporting for emergency department imaging?
No, so definitely not. So I think what this project has shown is that the AI sort of is great at aiding sort of clinicians, both the radiologists and the emergency medicine staff, but won't replace clinicians. So it can act as an aid, but wouldn't ever sort of replace the clinician.
But if it is comparable to a radiologist, why would we want a radiologist reporting as well as AI and the ED clinicians?
Mark, do you want to add anything?
Sorry, I'm just in the background. I think we still need to have the assurance it is not as good. We're getting there, but it's not as good. I think at some stage we will get to hot. This is de facto hot reporting for the ED. But even with that, we still see that there's some mistakes being made. We haven't switched on the learning for this AI yet, so it will learn, and hopefully we'll keep on improving. Ultimately, I think there may well have to come a decision if the governance stands over it, and we are happy that our litigations remain low, and that the public have accepted it. That it may well be that if we can show and maintain that level of comparability with our radiologists, maybe at some stage we'll get there. However, we'll never put radiologists out of a job. They've got enough work doing other things anyway.
Brilliant. Thank you very much. Thank you.
Thank you.
Thank you. Next up, we have Charles Berry presenting on improving documentation and clinical application of FRAX assessments. Please start when you're ready. Thank you.
Hello, my name's Charles. I'm one of the F2s at Sherwood Forest Hospitals. So this is my audit and quality improvement project on improving bone health assessments. So I work on a geriatrics ward, and one of the big things that we do is assess patients' bone health and decide if we need to do anything about it. And it's really important because fragility fractures are a significant burden for patients, so they lead to pain, loss of independence, and also a burden for the NHS. It was 5.4 billion of our costs in 2019. So it's a big part of what we do, and the way that we do that is FRAX assessments. But the National Osteoporosis Guideline Group recommended further additional things to check and do to assess patients' bone health accurately. And what I found was when we were looking in the notes that people were just writing low risk, high risk, and then we didn't know what risk factors they had considered. So we audited this, and we found that people weren't writing the risk factors they were using, and they weren't writing whether they were using falls uplifts. So what we did was we designed this sticker, and it implements the FRAX assessment as well as the National Osteoporosis Guideline Group's recommendations, which are evidence-based. We also involved the team, so we told them about it every board round, and we orientated new team members to the sticker, so they knew what they could use and what we were all doing on the wards. And if you go to the next slide, please. And this significantly improved documentation, and we were more assured that the assessments that we were doing were accurate and evidence-based, so patients were getting effective care, and know that their bones were being assessed properly. Going forwards, we're rolling this out to other wards, so they're also doing this, but it's difficult because getting teams invested and using something new. So we're going to try with posters, but it's not as effective because they just sit on the wall with loads of other posters. So we're going to try and get Frax champions. So train up a junior who knows about the sticker, can encourage people to use it and know how it's going to improve health. And we're going to try and obviously do run charts with that. So we have more cycles, more iterations of this to go beyond this audit to make it a quality improvement project and improve the service. So yeah.
I think my question was saying that's an amazing increase and improvement, and how can it continue? I suppose if you cyclically change the residents and the doctors on awards, then you're going to. Is there any other sort of part of the workforce that you could liaise with to support this?
Yeah, definitely. So especially on some of the other geriatrics wards, there are ACPs and they're there all the time. So they don't peak and trough, and same with the consultants as well. So what we found was if the consultants were quite invested in the sticker, so they knew, like, you know, when you're on the ward round and then they say, oh, you do a Frax assessment. If they encourage the junior to use the sticker, the junior will do it. So consultants for sure, and also the ACPs that stay there. But yeah, rotating juniors is really difficult because they move, they're on calls, and they just want to do the quickest and safest thing possible. But if it becomes habitual and it becomes part of the service, then that's beneficial. So yeah, ACPs and consultants are sort of what we're trying to target at the moment.
Brilliant. Okay, thank you very much. Well done.
Thank you very much.
Thank you. So next up, we have Miranda Giddens presenting on improving discharge information for paediatrics patients, QI. Please start when you're ready. Thank you.
Hi there, my name is Miranda. I'm one of the F1s in the Royal Devon Exeter Hospital. So we were looking at the discharge information we're giving to paediatric patients and their carers. So in Exeter, we use an online system called Epic, which means that a lot of things are automated, which is really, really good. So it makes our lives a lot easier. However, on the flip side, it means that things may not be regularly checked. So for these discharges, they're called things called smart phrases. And you honestly type 3 things in and then it comes up completely and you send it off, which is good, but it means you may not always necessarily check them. So I was looking, and we were also checking basically whether these discharges or smart phrases, where they were compliant with current national guidelines. We used the Royal College of Paediatric Children's Health and also the NICE guidelines to make sure they were compliant with them. And then we then looked at discharges, all of them, and we excluded ones which had been reviewed, updated in the last 6 months. On the left is an example of what they looked like, and after we then checked with them, we then audited them. Can we go to the next slide, please? So what we did, we looked at them. Overall, there were 20 smart phrases or discharges, and they ranged from things from quite serious things like head injuries or first seizures, all the way to mundane things like stomach bugs or upper respiratory tract infections. Overall, we looked at 16 out of the 20. 4 were excluded because they were updated recently. Out of them, 81% weren't compliant with national guidelines. This would including things like incomplete information, so they didn't include some extra symptoms that would be really helpful for carers. Inaccurate follow-up information, so some of them didn't include any follow-up, and then more recently suggested they should be checked up in 6 weeks' time by their GP. And also things like specific medical criteria. So some things were changed about how many wet nappies there should be, which weren't on them. And then after we re-audited them, and then 100% were then found to be compliant currently. And what we learned was that firstly, it's really hard to keep track of these things when it's an online system because it's done so quickly and automatically. You don't think to continuously check them. And it's less likely to be checked to be compliant. We've also now created a committee to regularly update them and make sure that they're compliant. And we're also trying to implement that then so that the ED department can use them as well, because everyone can get access to it. We're trying to make sure that that's the next step. So that's everything we did. Thank you.
Sorry, trying to unmute myself. And how do you ensure that the smart phrases are actually used in discharge summaries?
So that's a really good question. So what generally is happening now is that they're spreading from the previous group of people to the next one. And because in the pediatric department, they change over at different times, it's quite easily spread. However, they're now changing, we're trying to implement it so that when people start, they get given a list of ones to find and then get given to them automatically so they can then add them, basically, which is a bit of a struggle now, which is the next step that we're trying to do to implement.
And whilst these phrases 100% compliant with the national guidance, does that sort of lead to increased satisfaction from the parents?
So we haven't done that as the next step. I think that we're interested in doing that next, but I think we've spoken to other juniors and they found that they think the information is more useful, but I think it's a good way for us to do a next step of trying to like look further into this. So I think after we did this, we found lots of avenues to go and explore down. But yeah, I think that's definitely one we're considering doing.
Brilliant. Thank you very much.
Yeah.
Thank you.
Thank you very much. Next up, we have Vineet Kokingada presenting on improving anticoagulation use in primary care for patients with atrial fibrillation. Please start when you're ready. Thank you.
Thank you. Good afternoon, and thank you for joining me today. My name is Vineet, and my audit focuses on a critical aspect of atrial fibrillation management, the use of anticoagulation therapy to prevent stroke. AF is the most common cardiac arrhythmia seen in the general practice and increases the risk of stroke by up to 5 times compared to the general population. Anticoagulation therapy can reduce this risk by approximately 60%, making its use and patient adherence essential. Despite clear guidelines, such as recommending anticoagulation for most patients with the CHA2DS2-VASc score of 2 or more, many still remain untreated. This audit aims to assess how well our practice is managing anticoagulation in AF patients and to identify any gaps in care and opportunities for intervention. According to NICE, 70 to 95% of eligible patients should be anticoagulated, and in our review of 366 patients with AF, 22 patients, or approximately 6%, were not prescribed anticoagulation, highlighting opportunities for intervention. Next slide, please. So I conducted a detailed review of each patient with AF whom were not on any form of anticoagulation, collecting data specifically on their demographics, their CHA2DS2-VASc and Orbit scores, the anticoagulation status, and any documented reasons for no treatment. I also reviewed their comorbidities and their medication history. In cases where the rationale for not prescribing anticoagulation was unclear, I contacted these patients directly. For those where anticoagulation was not indicated, I updated their records, added codes to avoid them from being flagged up in future audits. For patients with a clear indication for treatment, but no anticoagulation, I initiated discussions, provided counselling, and appropriately commenced anticoagulation for them. A re-audit was conducted 4 weeks later and identified 13 patients still not anticoagulated, including 6 new patients. I presented my findings at the partners meeting, highlighting the concerning emergence of new untreated cases shortly after the audit. To address this ongoing gap, I proposed 3 main strategies, including improving documentation of clinical decisions, implementing alerts on System 1 for untreated high-risk patients, and most significantly, introducing a System 1 pop-up that triggers when the letters of AF or words of atrial fibrillation is entered. This alert would display the CHA2DS2-VASc and Orbit scores, prompting the clinicians to document and assess anticoagulation needs with clear justification. Thank you.
Thank you very much. The 13 people that weren't anticoagulated, but you'd already sort of mined the data 6 weeks before.
Yeah.
So were the 6 were these people who were they coded differently? What were these patients?
So I think they could be just new patients with new diagnoses. They could also, again, like you said, they've been newly coded. So whether that's because they've got letters from cardiologists or from the ED, these letters, they go to the secretaries and the secretaries then code it and send it to the GPs for their review. So yeah, so it could be a mixture of different things, but mostly it'd be new letters, yeah.
So what are you planning for the future? Because it's not really a re-audit, it's a sort of finding new cases. So are you planning to look again in the future?
Yeah, so I mean, I've obviously now moved on from my rotation, but I said with the recommendation, they said they definitely look at implementing it and seeing if they can turn it into a bit of a quip, seeing if there can be any kind of moving forward, how the recommendation works out, if we can reduce this, because obviously after completing the audit, to have 6 new patients, it's quite shocking. So I think that they're definitely having a look into that, but I think I would quite like to go back and see if anything can be done with regards to that. And I have let them know of my keenness to do that.
Brilliant. Okay, thank you very much.
Yes, thank you.
Thank you very much. So now we're moving on to our final presenter for the session. Next up, we have Elena Bornheim presenting on assessing compliance to the post-operative colorectal ERAS protocol. Please start when you're ready. Thank you.
Hello, my name is Alina and I'm an FY1 in the Belfast Trust. And today I'll be presenting an audit on assessing compliance to the post-operative colorectal enhanced recovery after surgery, or ERAS protocol. The ERAS protocol is an expertly derived guideline designed to reduce perioperative morbidity and accelerate recovery after surgery. Acceptable compliance is defined by the ERAS Society as greater than or equal to 70%, which significantly improves 5-year survival and clinical outcomes as per Gustafsson et al. 2016. Since changing from paper to Epic software in the Belfast Trust, compliance had not been audited, which posed a risk to patient safety and post-operative outcomes. This was a closed-loop retrospective audit examining a total of 47 patients undergoing resectional colorectal surgery. The post-operative items audited were multimodal analgesia, thromboprophylaxis, and post-operative nutrition, as seen on the right-hand side here. Next slide, please. Positively, outcomes displayed acceptable compliance to VTE prophylaxis prescribing for both laparoscopic and laparotomy patients. However, there was unacceptable compliance to both analgesia and nutrition prescribing. One of the issues was identified as a lack of awareness of the ERAS guidance amongst resident doctors. As such, the protocol was not being prescribed in its entirety for the correct duration. Errors were predominantly related to timely step-down of opioids and time frame prior to prescription of post-op nutrition. These issues were highlighted to the senior members of the team at the weekly colorectal meeting and communicated to the new rotation of resident doctors using an ERAS guidance summary sheet. Following this improvement, on re-audit, there was evidence of improvement to oxycodone prescriptions from 67 to 77% for laparotomy cases and from 67 to 91% for laparoscopic, thus successfully reaching the acceptable standards set by ERAS. There was also evidence of improvement to Fortisip prescribing. However, this was unfortunately not close to the acceptable standard. Considering these mixed results, a better approach would be in-person teaching sessions at induction for each new rotation of resident doctors that highlights the specifics of the protocol. In addition, we are aiming to create a shortcut on Epic to highlight a medication review to be used on the ward round. Current evidence supporting the ERAS protocol applies to the guidance as a whole rather than for individual items. Therefore, it is in the interest of patient safety to continue regular auditing to promote acceptable compliance to each item. Thank you.
Thank you very much. So the intervention was a prescription advice document. And is there any other, apart from the resident doctors who change very frequently, are there any sort of long-term members of staff that you look to speak to?
So in the wider MDT, there's the ERAS nurses, but also the pain team, which are responsible for advising us with regard to PCA step down, for example. So I think in the future, on another cycle of re-auditing, it would be interesting to involve the pain team in this as well, and just to seek their advice as well. But then obviously, the consultants are there long term as well. So I think the shortcut on Epic would be particularly useful, just because then it's just a memory jogger on the ward round, just to see if there's anything that can be changed with regard to the prescriptions.
And what is the role of the ERAS nurses?
So their role is to check that we are compliant with the ERAS protocol. But the ERAS protocol it's both pre-operative, intraoperative, and post-operative. So their role is quite widespread. Hence why I chose to focus on the F1s and the F2s, who would be prescribing a bit more regularly.
Okay, brilliant. Thank you very much.
Thank you.
Thank you very much. I believe that's the end of this session. I just want to say a massive thank you and well done to everyone that presented. Everything's really interesting. It looks like everyone's doing some really positive work to try and improve the state that everything's in at the moment. So just thank you. I don't know if you want to add anything, Angela.
Yeah, I'd just like to say thank you for everybody. The standard of the presentations was phenomenal, and also the slides were great. So thank you for all of the hard work that's been put in such a high quality.
Thank you. So just a little update. We've really sped through the presentations, so we finished slightly early, but the next presentation will be at 5:55 by Adrian Fowler. There's been a slight change in where this will be taking place. I think originally it says it will be on the main stage, but a new session has opened called Progress on Martha's Rule. So if you look for that, the next talk will be in that session. So thank you. I hope you enjoy the rest of the conference.